we've got a good 10 minutes, is if you have a question, I want you to type it into the chat. If you have a specific person you're directing your question to, you could type in their name. What I'm hoping though, like this first question, ooh, they're going to be moving fast. This is going to be challenging. It might be directed towards one person, but I want other people on our panel to speak up if they would like to contribute to it. So I'll
start with the amantadine question while people continue to type.
Please do.
Amantadine is becoming increasingly used. Again, targeting some of these generalized brain dysfunction symptoms means that it's going to be used in lots of different populations, and certainly used in people in a residual state after autoimmune encephalitis too. To my knowledge, there is not specific evidence looking at effectiveness of that medication in just this population. Most of the studies are in kids who have other neurodevelopmental differences that are affecting cognition, state regulation, and then also in traumatic brain injury. I will say that the data in those groups is not super robust, but the medication is otherwise very safe in general. And so oftentimes people are trying it as a trial to see if there's some benefit without side effect, but it is not going to be some major difference, but is something that's safe and reasonable to try, but to come off of if it didn't have a benefit for an individual. Psychiatrists have been using that medication a little bit more. And then again, people who see some of the more notable brain injury, so rehabilitation specialists and some neurologists.
Great, thank you. Another question that I see is there any research on eating an anti-inflammatory diet to assist in recovery? Anyone?
I have a feeling no one's going to jump into this because there's not really any data. I can speak from the larger rheumatology space in autoimmune disease. I think this is an area of a lot of interest in the kind of role of gut and autoimmunity. I think there are right now more questions than answers. I think in general, a healthy diet is good for you. We should all not eat a lot of simple sugars. We should all eat vegetables and fruits. We should all be careful of what meats we're eating. And so I think there is evidence that that is just healthier for us overall. The true anti-inflammatory diet, I think, is a little less clear, scientifically speaking. But the foods I see most commonly from rheumatology in general that can be immunogenic for some people. Gluten is obviously a big one, even if you don't have true celiac disease, and dairy would be the other big one. So a lot of people do an elimination diet. Usually you can do 2 to 4 weeks of an elimination diet if you want to see if that helps you. I recommend you do one food group at a time, just because otherwise you could be really eliminating lots of things and then slowly adding things back in. So, and I usually recommend starting with either gluten or dairy elimination. Always you can get rid of simple sugars, and anytime we should all probably be doing that. And then there are some supplements that are certainly been found to be helpful for autoimmune diseases in general. So vitamin D is one, and omega fatty acids are the other. Basically, any trial done in fish oil has shown it to be beneficial. The joke is you usually need to take enough of it to smell like a fish, but it is definitely not bad for you. It's good for everything that's been studied for: cardiovascular, oncologic, neuro, you name it. Fish oil is good for you. So those are the two that I definitely recommend. There is no data that doing high dose vitamins of any kind are helpful. So you want to just be on like healthy range vitamins. There actually can be significant side effects from some of these hyper dosing of vitamins. Vitamin D, we started to have more issues with because people got very conscious about vitamin D supplements. And there was some, I think, probably well-intentioned initially, but the idea that if you had a higher vitamin D, that must be better for you. That has not panned out, and we actually saw a lot more side effects from people with too much vitamin D. So just being thoughtful about just normal supplementation. It's best to get vitamins in your diet. It's absorbed better. Turmeric has some anti-inflammatory benefits too. It's actually best if you eat that. So it's an oil-absorbed not really a vitamin spice, I don't know. And so it's actually best if you saute it in some oil and then cook with it. That's the best way to get good absorption of it. But there are definitely some anti-inflammatory benefits of that. So I don't know if that answered the person's question or not, but
a lot of good
a little bit of hand waving. A little bit of like, yep, what grandma told you, chicken soup is good for you when you're sick. A little bit of that rings true, but in general, don't overdo it.
Okay, and we're getting a variety of questions. I feel like we're kind of maybe a little bit off of recovery topic. So I would love to see more specific about recovery, but I will also say to the panel, anything that you read that you want to address, I want you to do that. But I also want to try to stick with recovery since that's what we're talking about today.
Meg, can I ask a question to the other pinned panel members?
Yes, you were on both sides of this, so you get to.
I just had a question about the recovery and the like chronic. There was a slide I think you showed where it showed like chronic inflammation or like the chronic recovery and the different like mechanisms of, you know, you might have like a week or a month and then everything's better, or it might be chronic and remitting. How do like treatments come into play? Because I know a lot of us had kind of like waived like this chronic course for many years because of the treatments we were on. And then we got much more aggressive in our treatment strategies. And then we kind of had this very drastic recovery. And so is that like recovery that we keep talking about and kind of the course of the disease, does that take into effect the treatment strategies, or I guess lack thereof, or like how does that come into play? Do you expect it to be this chronic thing, or?
Yeah, I want to kind of just expand that question a little bit, and then Dr. Graham, if it's okay, have you kind of address that from a layering of immunomodulation and then peeling back kind of standpoint. But so essentially, you know, if during that, to go back to that down mount chart where you had kind of that initial phase and then that worst part, and then you're starting back up, if you start up maybe from the worst, but then stall, but you're way off a baseline. Depending on how low you are when you stall, what the symptoms look like and how you're responding maybe to treatment tweaks is very important information for you and your team. And so there is a space in between that nadir, that low point, and your ultimate baseline where there's exactly what you say, like, oh, is this it? And I'm in that recovery phase, or is there still more dynamic stuff? And I think some people have asked those questions, and that is hard. And I will say that obviously it's not going to be the same for everybody. It's not going to be the same for every disease. And it's not going to be the same necessarily depending on what's going on. But one of the key features is to recognize that the symptoms shift a little bit as far as what they look like, and then they can still bounce a little bit. And so sometimes a tincture of time during that process to be like, I think I noticed this. Let's see if it sticks. Let's see if it builds, right? Are we building in improvement, or are we building in symptom add-on? And so sometimes a little bit of patience to time will help, but then we'll let Heather talk a little bit more about the actual treatment durations and layering and how that muddies the water, but sometimes needs to be done.
Yeah, so I'm going to group this into 3 groups. So I'm going to talk about side effects for the medicines that really complicate things. I'm going to talk about onset of the drugs from an immunotherapy perspective. Some work immediately, some have delayed action, and then how long they work for. And then someone had asked this or mentioned this in the chat when Carolyn was talking. And I think when we're talking about rehab and mental health, and I do love this too, Meg, the mind and brain together, we should be open to always thinking about, is there active inflammation going on as providers? Or is this adjustment or recovery, right? But our patients, we also want to be in that same space where we're going to think about these things equally. We're not going to try to anchor too much on adjustment. We also don't want to anchor too much on inflammation. So we want to make sure that we're open-minded, that we're thinking about both, and that not finding inflammation as the reason for building symptoms isn't a bad thing. It just means we need a different targeting of therapy. So number 1, for the side effects of medication, steroids can really wreak havoc on you. Steroids can make you psychotic in and of themselves. It is a rare side effect of steroids, but can happen. They make you really moody. They make it so you can't sleep. So depending on your dosing of steroids and how you're coming down on them, you may have different evolution of symptoms. Some people feel really good on steroids. I am one of those people. You put me on high dose steroids, I feel great. I'm already a pretty high energy person, and I can accomplish anything when I'm on steroids, right? So if you're one of those people who has that lift and feels a little bit more energized and like feels good and people start coming down in your steroids and you're not feeling as good, you want to be thoughtful about, is that really a worsening of my disease, or was this a little artificial inflation of my energy level when I was on the steroids? Vice versa, if you're somebody who had a lot of bad side effects of the steroids, you may need to come off of them a little faster. And we just have to be thoughtful if we need to layer another medicine in to cover that, the beneficial effect of steroids you were getting. One thing, there's a question in the chat too that we see all the time when we're spacing IVIG. So our group, we don't stop IVIG. We tend to space it to make sure people stay overall pretty stable, and we taper it off that way. It is very common to see as you get close to your next dose of IVIG that you don't feel quite as well. And we used to think that this was related to active inflammation. And I then learned from my AI allergy immunology colleagues who use IVIG just as baseline supplementation, that they would see the same thing in their patients, even when they didn't have an autoimmune disease. And it seemed to be something about either how IVIG is metabolized or some of these ways, we don't even know all the ways IVIG works, where they would see this little less energy, maybe a little irritable, not quite feeling as good. Patients would feel like, I must be coming due for my IVIG. So we want to differentiate that kind of general, not quite feeling as good, being a little off my game energy differences as you're tapering IVIG, and kind of push through that a little bit. And what we found is that people often will say that, yeah, I feel like I'm coming due at 4 weeks. And when we try to push them to 6 weeks, they feel the same way, but it's more like that 5 to 6 weeks. They're getting closer and they can kind of slowly space that out as we get to that. Versus the wheels start falling off. We often use the wheels falling off analogy too, where you're starting to see a layering of a lot of the symptoms come back, where you kind of then question, is this the disease coming back? Someone asked before, how do you know if it's inflammation or not? We honestly, we can never know for sure, right? So we're looking for a combination of symptoms that come back. Sometimes we're looking at repeating an MRI or an EEG or LP to see if there's any signs of inflammation or autoimmunity. And if we can't find those signs, so those times when we really can't tell, this really could be 50-50, then it is sometimes necessary to repeat those studies to kind of look for signs of inflammation. And if you're not seeing any, to really think that while you can never completely rule out inflammation, it's very reasonable that you go down these other routes for thinking about rehabilitation. And then the last layer I put in is how long medications work. So something like rituximab usually works 4 to 6 months for most people, some people up to a year. It has a pretty variable duration of effectiveness in different people. Something like tocilizumab, kind of like by 2 months, it's not totally out of your system, but wearing off. Similar for IVIG, can last several months before it really is out of your system. So you want to look at how those symptoms are evolving as you're tapering or adding on different medications or coming close to a time when a medication may be wearing off. And that's just another point of information. It does not make the diagnosis, this must be off inflammation because my rituximab dosing is now wearing off. You want to also be looking at all the other things that are going on in your other medications, in your life in general. Did you just start back to school or start back to work, or other stressors that can contribute to some symptom evolution? I don't know if that answered the question or what you were thinking of, Carolyn, but.
Yeah. And Dr. Mitchell, I've been tricked before. I've had people who have had, some improvement, but still not great. And we're worried. And so we'll layer something on and we'll get some more. I'm like, yay, we did it. But then whenever you really look at some of the controlled studies, particularly again, an NMDA receptor encephalitis, sometimes, we'll change meds or add meds because we're being impatient. Where actually, whenever sometimes they're controlled, that recovery was going to kind of keep going at a rate that wasn't great. So did we actually make the intervention, or was that part of what was going on anyways? A question. And then let's say you do layer and you get some more boost at some point, you still have to be able to do some of that spacing and pulling back. Again, what condition? Is it one of these conditions that we know is lifelong chronic and we just want to get back to a minimum, or is it one that we're hoping is monophasic with a low rate of flare? And using some of that information can be helpful too. But yeah, it's that hard on that hill back up to know how much control we have. And then obviously, as Dr. Romano was saying, not everyone tolerates the medications well, and make sure we're being thoughtful about that, and not giving people medicines that are actually making them feel very badly as well.
No, thank you both. That's just the question I get asked a lot, and it's a question I see patients ask a lot. And I know for me, I had an advantage of being able to know, like, I was doing neuro checks on myself every day, and so but for me, that's an advantage I have that not everyone else has. So kind of knowing what to say. And then there aren't very many providers necessarily who are experts at this. So patients who then, know what to say to their providers, like, I think this symptom is coming back, versus, to help them make that decision, I think is very helpful.
Yeah, and we talk about in our clinic a lot, like, You can have the same symptom, but for different reasons, right? And so that's the tricky part, headache, right? You can have headaches for lots of different reasons. And if you had headache before, because you got hit in the head with a soccer ball and you have headache now, doesn't mean you got hit in the head with a soccer ball, right? You can have for a different reason. And so sometimes it's hard when you didn't have a symptom before you had AE, and it was a big part of your AE manifestation, and maybe it got better or got more controlled. And now it's turning the volume back up again, to not naturally say, well, this must be my AE because I didn't have this symptom before. But sometimes it may have kind of unroofed something that's now going to be a symptom. You're going to have more headaches, or you're going to have more anxiety or worry, or maybe a little bit of a movement that will come back, and trying to figure out then what's the underlying reason for it. So I think whenever you're talking to your doctors, I think one of the things that's really helpful is to just speak honestly about what the symptom is you're experiencing, and say, I think you can say, I never had this before I had AE. I had it as a big part of my AE manifestation. Now it's coming back again. But to have that full conversation with your doctor about which parts may be related to active inflammation or not. And that is a tricky discussion all the time. And I think it's important for all of us to make sure that we don't anchor too far on one side or the other. I have certainly anchored on, oh my gosh, this must be inflammation, and way overtreated people. And I have also thought that it's not inflammation and undertreated people. And you will hear stories of like the person who the doctor ignored a symptom and it ended up being active inflammation. You're probably less likely to hear all the times when it wasn't active inflammation and it was somebody who required an SSRI or a different kind of therapy, right? So we just want to make sure we're having a really fair and open dialogue, that we're all keeping each other honest about this very gray and muddy space, because it is really tricky. Because I think what we want to just make sure is that people don't get too like we're on, and everybody should be on the same side, right? We shouldn't be trying to convince my doctor, and my doctor shouldn't be trying to convince me. And we should really be listening and having an open conversation, really trying to understand the perspective of the other person. And I think that helps in this space, although it's very imperfect.
Another question that came up multiple times, and I want to make sure we address it, is our speech language pathologist usually referred by our neurologist? And several people want to know, Melissa, do you just treat locally, or I think people want you to come to their homes basically after all that you shared. So you've become quite popular. And so yeah, how does somebody get a speech language pathologist? And how do you find one like you? Those are the two questions, I think.
Can you hear me is my first question.
Yes, you sound great.
Okay, my coworker's laptop. Okay, so I treat in New York. I'm licensed in New York. So the people that live in New York, that's the relationship that I have. So I can't treat out of state. My suggestion for somebody that's looking for a speech language pathologist would be to connect with their neurologist, because I'm assuming and I'm hoping that they have affiliations with neuro rehab facilities, whether it's outpatient. Sometimes therapy can be done remotely if you're not close to a facility. But I think a neuro outpatient rehab program, whether it's an occupational therapist or a speech therapist, can help put a program together that would help. In terms of insurance, if insurance will cover it, obviously it's just really different for every insurance carrier. So if something is medically necessary, I try not to put too much weight in terms of the timeline. So if somebody had an onset a year ago and never had speech therapy, I would still encourage an evaluation to see if it's covered and justified, or at least to get guidance. And then for those of you that may be out a little bit further, but still feel like you can benefit, the local universities in your area or state have speech language pathology programs that have licensed therapists that are training students to become therapists, and they have different clinics. So oftentimes if people still feel like they need that structure and stimulation, I taught you everything I have, but you still need that like weekly reinforcement to use it and exercise it and have that check-in. Usually that's like my post-discharge recommendation, to connect with a university to have that structure. I hope that answered those questions.
And regarding finding someone with experience with AE, Melissa, I would recommend somebody who really specializes in brain injury. I mean, it could be concussion or TBI, because a lot of those same principles will apply and I think be very translatable.
Agreed. I'm partial, obviously. This is where I live.
But I think it'll open up your options.
That same question sometimes comes up with psychotherapists or psychiatrists, and that, do they need to have special training in AE? And our rule in our RP's program is no, not necessarily, because oftentimes the treatments that help for these adjustment-related depression or anxiety, as Dr. Pizzoli said, respond to the same therapies and interventions. I think you want to make sure that your psychiatrist is talking with your neurologist, your immunologist, whoever is helping manage, because sometimes if you're changing a med and then suddenly there's a big uptick in some of those psychiatric or behavior symptoms, you want to make sure people are talking about, one, is my med causing that because that's a side effect, or are we not treating effectively? So you just want to make sure they're in a good communication loop, but they otherwise don't themselves specifically have to be an AE expert, again, because it's going to be hard to find them and you're going to potentially miss out on really helpful and valuable therapies that you'd benefit from, and that they do have the expertise to use safely.
Okay, we are at 3:09 on the East Coast, at least. I don't know, for those of you on the panel, if there's any other questions you saw that you would definitely want to address, because I don't want to, I mean, we can't answer everything, but if something popped out at you that you would really like to touch on, I want to take the time to do that. But I also want to be aware of the fact we've been here for over 3 hours and we probably need to start moving again. So anything you noticed? Anybody?
I think I would encourage, again, I think for lots of reasons, lots of people, picking a couple of things, like you can't change everything all at once, you can't do everything all at once. So kind of focusing. And so if you think about the core symptom bins, where do you think most of the issues lie? And pick a couple of things, kind of start some things and then add and layer. And then if you need somebody to work with cognitive communication therapy, like a speech pathologist or an occupational therapist, to work on some things to adapt in the home, work, or school environment, adding in, right? So it just depends on where you want your efforts to be. Eggs in a basket, kind of put a little bit in each, but concentrate and layer in. But truthfully, you get to the point where you kind of have to be your own rehabilitation director, working on the intensity and the duration and the time. And then these other people are kind of like your coaches you see intermittently if you get far enough out into that chronic phase. And that's hard. I have things that I've been trying to better myself on in my life by using those same kind of things. And I have not always been successful. And I wish that we could harness that one a little bit better.
Okay. One thing I would like to do, anybody that's been in a meeting with me before, I really love to wrap up a meeting by checking in with everybody and kind of having a closing moment. And we still have 42 people in this call, so we can't do that. But what I would love at the beginning, I made a comment, I don't even know where it is anymore, that I would love it if everybody today learned something that they felt was helpful and that they could take into their lives and keep doing. So for those of you that joined us today, if there's anything that you could share with these presenters so they know that they were successful today, but hopefully they already all know that. What's something that you maybe learned today that you're going to go tackle or incorporate in your life? If you could put that in the chat, I think it would mean a lot to some of the people that have joined us today and given us their time. So share something if you can.